Hello, everyone. Welcome to the Ophthalmology Business Podcast. We help you develop your ideal practice with help of other doctors and experts. The topics we cover include marketing, management, leadership, recruitment, HR, mindsets, and more. I'm Guido Piquet, one of the co-hosts of this podcast. Every listener of this podcast is welcome to join the Ophthalmology Business Academy at www.obacademy.org. The membership is on us, and it's our gift to you. Today, I'm excited to talk to Dr. Dana Ondrias, the CEO of Mann Eye Institute, about co-management compliance insights. Let's jump in. Dr. Ondrias, how are you this evening?
I'm great, thanks.
Excellent. Thank you so much for joining me in this webinar/podcast. We'll see how it goes. And so I want to start off, I'd like to start just by getting a little bit of information about you. We heard your bio, but can you just let us know kind of how did you get into the eye care world and just a little brief history of that?
Sure. Actually, oddly enough, I knew I wanted to be an optometrist from the time I was 16 years old because I worked for an optometrist in my hometown. So it got me interested. He was passionate. And he was really great at what he did, and he became my mentor in the field. So I got into that, and he was in a small rural town, which is where I grew up. And we did a lot of co-management of cataract patients at the time. And that was very on the edge of what things needed to be done and how things needed to be done. So it's changed a great deal from then to now, and I've watched that. But as I've rolled with that, both doing it in LASIK and both doing it through other refractive procedures, as well as now cataract procedures, and then premium lenses come along. So it's an ever-moving and evolving field, but it's really necessary. And we'll talk a little bit, about when it's appropriate and why things do. But that's kind of how I got into optometry and into the world of co-management, and how I ended up running parallel in the world of ophthalmology. I can't believe it's been 27 years, but it has.
So you've seen a lot of changes from the time that you started until today. I can imagine.
Without a doubt. There's definitely been, I think the reasons for co-management haven't changed a great deal, but how to go about it to remain compliant, and how do you remain compliant when there's the cash portion that's brought into the world, and what changes with the diagnostic testing in advance, and who performs that, and who reads the testing. Those are all things that you have to kind of watch and monitor as things go forward.
Makes sense. Well, let's take a step back and talk about a definition. I know you hear the word co-management. Everybody thinks they know exactly what it means, and I've heard 100 different definitions. So can you just briefly tell us what is co-management and why does it exist?
Sure. So co-management was originally designed exclusively for the benefit of the patient. It's a patient care tool for providers. It's always a patient's choice to be co-managed. And there's various reasons as to when it's appropriate. But it's an appropriate and beneficial tool when it's arranged on a patient-by-patient basis. So not every patient wants it, not every patient needs it, but it is a tool that exists because most patients choose it for the reason of the continuity of care. They enjoy the long-term relationship that they have with their optometrist. They have a trust built in there. It's usually more convenient for them to go to an office to that aspect. But the patient actually makes that choice and decision, as the episode occurs. Sometimes there's an inability for the patient to get in with the MD. Either the schedule is full or they travel around to multiple locations, so they can't get back to that location for whatever reason. So that's also a reason and a need for co-management to exist. The doctors need to agree on the transfer of care during this period. That's a patient-by-patient decision as well. Sometimes patients choose to stay with the ophthalmologist for whatever reason that makes them comfortable. So that also needs to be addressed. We work on things from that aspect, but it's always the patient's choice. And as long as you keep that at the core of what you're deciding to do, and you don't have it as a stark rule of you give me the patient and I give you X, that's where you can start to bleed across the line.
And you mentioned a lot of good things, but I think before we get into the nitty gritty of some of those details, why is it such a hot topic today? There's reasons why I think that it's important, but from your perspective, why should we be talking about it right now?
I think across the field of healthcare, there has been a great deal of healthcare fraud, not just in ophthalmology, not just in podiatry, not just in, but all the way across. It's touched the pharmaceutical industry. It's touched various different referrals, and especially CMS on Medicare, Center for Medicare and Medicaid Services. They're really looking for fraud. Durable medical goods, like the walkers and the scooters that were done, that was really dove into, and that actually many optometrists understand and know that, because it changed the way any Medicare patient gets glasses. It's really difficult to file and get Medicare to pay for any type of glasses for patients now. So as that field moves forward, there is a great deal of money from Medicare that goes out for cataract surgery, as you can imagine, if the patient lives long enough, they have it. So there's a whole lot as far as volume. Retina is also another area that they're looking into. So ophthalmology takes up a big chunk of the budget for Medicare. So they've started looking at it a little closer. So as they've looked into it closer, there have been some complaints filed to them, usually from disgruntled employees of various practices across the country, and they've resulted in lawsuits. So the lawsuits that have come to light recently have really put a spotlight onto co-management and what's appropriate and what is deemed a kickback or something that shouldn't be done in the best interest of the patient.
And some of those lawsuits, some of those settlements have been pretty large, right?
Yes. And I think we're probably not through seeing them, but they've been into the millions, because they'll add up, and it's not a one-time fee. It's per patient that they go in, and kind of like unraveling a sweater. When they go in and find one little thing, they start pulling on that, and it really goes into the practice, into multiple things. So it's not just what are you, is there kind of an inappropriate referral relationship? It goes across the board as to what are you doing for them? What is the expectation on both sides? You can never have any type of financial benefit promised to any party that's involved. You can't have standing orders that this is exactly what I want and for all of my patients, because each patient has to be treated individually. You can have guidelines, but knowing that there's some areas that need to be changed up from patient to patient. You should never attach rewards to anything, such as if you send a certain number of patients, you can get a gift or tickets or a party invite or anything to that effect, because those are all things that definitely they found in some of these practices that were happening on a regular occurrence, and started making it a little bit a bigger deal. There should never be volume attached, discounting, pricing attached to any type of referral, because again, it really is a patient's choice to have the fee should be commensurate that's being paid for the work that's being done, and no more, not for parties or dinners. It even goes into, a lot of the lawsuits went into continuing education. And that's the reason. And when we take our ethics course every year, it's always, you shouldn't be having free dinners, and there aren't, there's really nothing free, so to speak. So when you have continuing education events and functions or dinners, that they're not free anymore. And it goes across the pharmaceutical industry as well. I mean, they don't do alcoholic beverages at the dinners anymore, and they don't do, you have to sign in for anything and everything if you decide to eat cracker off the plate. You better sign your name in there, and they're wanting your information and your license and your position. And so I think it goes across, all the industries, like I said, in healthcare, trying to stop fraud, but that's where it started from.
Yeah, a lot of the things that you mentioned, if you Googled the settlements in the few cases across the country, some of the things you mentioned were the complaints from the whistleblowers. And so when you start thinking about kickbacks and inducements for referrals, there's a few buzzwords that come up like Stark Law or anti-kickback. I think there can be some confusion between two. Could you just kind of describe each and what each means and what the difference is?
Sure. And there's a little bit of difference in the type of physician and the type of referring relationship that you have, but most of what we're dealing with is anti-kickback statute. And that is anytime, as a healthcare provider, you're a target for kickback schemes, obviously, because you're a source of referrals for physicians, other healthcare providers, supplies, you decide what drugs patients go on. So that kind of makes you a target. So anytime you're trying to make a decision that's based on any type of decision other than what does that exact patient need and what's best for them, then that's where you can start to say, maybe that's not what should be happening. When you talk about Stark Law, it's a little more it's what prevents. So for example, an optometrist from owning an ambulatory surgery center or a portion of a hospital or anything. You can't send a referral to an institution where you have ability to have financial gain from that referral directly, not in a payment, not in a fee that you're charging, but that you're referring to a facility that you have a financial interest in where you would gain. Same kind of thing. If you own a pharmaceutical company, you can prescribe your pharmaceutical to a patient on a regular basis. That's more on the Stark Law side versus the anti-kickback statute is somebody's paying you for the business. You're not involved in that business, but you're getting paid.
So in both of the scenarios, the decision wasn't based off what's in the patient's best interest medically. It's more of a financial incentive, either personally in the Stark Law for referrals back to something that you may have interest in, or getting some kind of kickback from somewhere that you're going to refer patients, and there's some kind of financial incentive. Is that accurate to say?
Yes, the kickback can be financial. It can be a gift. It can be a trip. It can be anything, anything deemed as not something that's specific to that patient's best interest. And that's the reason the laws exist, right? So they exist so that the patients don't get a clouded treatment.
Yes, I think I want my doctor making the decisions based off my medical situation, not how much money they can make, right? Mm-hmm. Just to round out some definitions, so you talked about co-management. I also kind of hear questions sometimes about direct referrals. So just real quickly, what's a direct referral versus co-management, and when are both appropriate?
So a direct referral is that you're referring the patient in, but you're not going to be involved in the either postoperative care or the management of whatever that condition is. So you may have a direct referral because somebody has a retina problem. You're going to have a direct referral. You're going to have a direct referral if somebody has maybe a pterygium you want removed and something's not in. Those are all direct referrals that are coming in from a referral standpoint. And when the patient's global period or treatment is taken care of and the doctor deems, okay, they're done with this episode, then they go back to the referring doctor, where co-management is specifically different, becomes a little more complicated in the sense that the patient is sent in and then you share the care. And share the care depends on the timing of, when that is.
Okay. Well, I appreciate it. I think it's important to define kind of the baseline conversation of what we're going to talk about. So I want to get into some specifics about, the way that you can do co-management correctly. That way, I think some of those that are listening on the webinar or the podcast, they can take some pearls of wisdom when they start to analyze their current existing co-management relationships or new ones, because there's different practices that may approach optometrists, and some of the things that we may talk about, it's good to understand kind of what are the things they should and shouldn't do. But let's talk about some of the things that are important when it comes to it. So you mentioned patient doing it in the best interest of the patient. And along with the best interest of the patient, isn't it true that the patient themselves need to be 100% informed about the nature of the co-management relationship? So how do you do that appropriately to make sure that the patient is consenting and they understand?
So it's a great point. So yes, a huge piece of compliant co-management is that the patient is completely informed of the process all the way. And that means, when do I go to see the referring doctor both ways? When do I transfer my care? What am I going to pay? And what is the payment that goes to everyone that's associated or affiliated with this care relationship? And that's where it gets complicated, but necessary. And fortunately, things have progressed, and there have been newer payment platforms and softwares we can talk a little bit about that have made that a little bit easier. But it definitely needs to be shown to the patient. They need to sign it. We have those forms. We have them sign co-management consent compliant forms so that they can actually see, this is what the payment is, and this is the part that's going to the facility, and this is the part that's going to the surgeon, and this is the part that's going to co-managing doctor. They also need to know what portion is being paid to for anesthesia.
So thank you for teeing me up on that. I guess I'm going to show the visual aid that you sent so you can keep talking about that patient disclosure. So I just pulled that up here. So if you want to just go through it for the webinar. I apologize, podcasters, but we'll talk through it.
Yeah, this is an example of ours, but anywhere that you're doing any type of co-management should have some type of form that has certain pieces of information. And one is the patient, and the patient confirming the doctor that will be performing their co-management care. And they initial where it is their desire to have that done. And they can, for whatever reason, doesn't matter, right? It's usually, like we said, continuity of care, comfort with their doctor, or it's a long distance, or they just, in our case, sometimes they just don't want to drive into the big city. The traffic is an issue. So it doesn't matter why, it's just that needs to be in there that they're doing that. They sign it, it's witnessed, and then the fees that are going to be paid by the patient, the payments go into here, and it talks about what is in here. Now, we don't set fees. It's important to say we don't pay fees. What we do is provide the facility, provide the surgeon to do the surgery. And it's important that as we move forward, the co-managing doctor is the person that sets their price or fee for the service that they're providing to that patient.
And how does, so when they come into the practice, is somebody going through this and having the patient sign it?
Yes, when they show up here, they are given this form along with some other forms in their consent forms. So this is in their packet of forms that they sign before they have surgery. And this is filled out and signed and kept in their records.
Thanks for explaining that form and explaining it very clearly for the podcast listeners who didn't get a chance to see it. But you mentioned the different fees. So let's talk about payment really quick. So when it comes to taking payment, either the ophthalmology practice or the optometry practice, what are some do's and don'ts when it comes to payments?
So I think the biggest don't is easier, and that's that the surgeon doesn't pay the co-managing doctor. That really, I can't think of a scenario where that's appropriate. So I think the main do is that the doctor collects the fees for what the doctor does, period. So the fee needs to be commensurate with the work done, so that if you, for our standpoint, currently, we're doing first eye and second eye can be a little different when you're dealing with specific to cataract surgery. LASIK's a little cleaner because it's the same eyes, same day. And right now it is after the second eye, first day post-op is when it goes back to a co-managing doctor, as long as it's what the patient desires and that's what the surgeon feels is appropriate. If for some reason something happened or they're feeling like they need a little longer care, that's communicated as well. So again, each one's a little bit different from a snowflake, but that's the general ruling of where that goes from that standpoint. So once that takes place, then the transfer of care takes place. And the fee is then paid depending upon the timing of when that patient goes back. If they're filing, because they need to file with Medicare or the insurance with those modifiers. Now, the collection of the fee, you can do two ways. You can collect your own fees directly from the patient, and it's clean and clear and it doesn't pass anybody's hands. Or you can use a program called COFI, which is what we've recently, it's a program that's compliant where the patient shows up for surgery, they swipe their credit card or their financing one time, and then it's compliantly divided and directly deposited into the facilities account, the surgeon account, the co-managing doctor account, and anesthesia, if necessary's account as well. There's probably a little more on that on the end of the co-managing doctor with that set up, but that's really kind of your area, Guido. You can probably touch on some of that and how that setup works and what fees and the financing that's available now.
Yeah, absolutely. COFI, it's been great because there are some logistical challenges with collecting payment. And you mentioned insurance. So when a co-managing physician or the ophthalmology practice is filing insurance, the payment comes directly. That's clear and clean. When it comes to LASIK surgery or upgrades for premium cataract surgery, collecting the cash fee portion for those. Logistically, with larger practice like ours, it's hard because sometimes we've had patients that the co-managing physician says, well, I'll just collect the upgrade portion in my office. But then the patient comes into the facility that has surgery, we collect the facility fee. And then when the patient goes back to the optometrist's office, says, oh no, I already made the payment. Like patients think that, sometimes you tell them 10 times, you get them to sign a disclosure, they understand the fees, but when it comes time to pay, they forget. And so from a patient just ease of access standpoint and also practice ease of it for everyone, COFI has been a really great tool because, as you mentioned, when they come in for that procedure or even before, as we're trying to collect payment before surgery, we can collect that payment and then COFI then goes and splits the money and that money never touches the incorrect bank account. So if a co-managing physician collects X for post-op care for LASIK or premium cataract, or then that goes directly to them. And then it also doesn't appear if there were any kind of complaint of an inducement for referral, if there is an ophthalmology practice who is sending checks directly to optometrists, well, I think any attorney could probably in court make an argument to say, let's take a look at your financial records. Let's look at what was this check for? What was this check for? And so we've stayed away from that because we don't want to get into that kind of scrutiny. And they also do financing. They should not do financing. Sorry, this is not a COFI commercial, but I like the product and I think it helps us be compliant. And so you can do Alphaeon or Care Credit, and it again splits the fees. So yes, it has been a great tool. Just I want to expand a little bit too on payment for the co-management process. If an ophthalmologist does decide, depending on when they send the patient back, when the practice sends the patient back to the co-managing OD, does it matter when they send the patient back, and does that affect the fees that they collect?
So on the portion that either is going through Medicare or a commercial insurance, then it does. It's just you have to have the days. I mean, it literally pays for the first 90 days on the days. But so that part, yes. But if you go back to the upgrade fees, and what you're justifying for your fair market value and your fees, you'll notice that the care is beyond 90 days. So it's both eyes in the care from the 90 to 120 days. And, people ask, and I certainly am happy to give advice. Don't tell anyone what to do, but, what makes a difference between a premium lens and a standard lens in the postoperative care? So you're going to see them in approximately the same intervals, but the postoperative care of a premium lens patient and the preoperative getting them ready takes a little more time, effort, energy, and hand holding. I think there's no doubt that dry eyes affects every cataract patient, but it affects the premium lens patient more so than it does a standard patient because of the multifocality of the lens. So you really need to treat these people with a dry eye workup before, and you need to treat them afterwards for dry eyes, because dry eyes is a known complication from cataract surgery. But these people need a little more hand holding, and you also need to follow their refractive outcome a little closer. So I think you have to make your fee commensurate with what your office is capable of doing. So if you're capable of treating them for dry eyes postoperatively, you may have a different fee than somebody who doesn't treat dry eye and has no topography and doesn't handle the postoperative refractive complications that can come from premium lens patients. They're not complicated patients. They've just paid more money and they have higher expectations, and you have to really walk them through that. So that's really where you have to design your postoperative schedule and fee to that particular patient and what your office can provide them.
You touched on a couple of things that I think are worth diving into a little deeper. And I want to touch the first topic with talking about a question that I think we hear more often than I think we should. So if an optometrist asks, you or somebody who works in an ophthalmology practice, what do you pay for post-op care? How would you respond to that?
I get that all the time. Got it this week. So I tell them I don't pay for postoperative care, right? We provide the facility and the surgeon and what happens. Now, depending on the patient and what you're going to do in your office, we suggest this is what we charge for our postoperative care fees. You're welcome to design your own postoperative care fees. And I'll tell you, all over this city, they're very different depending upon what that doctor does provide. Some of them provide additional visits. Some of them provide sunglasses postoperatively to these patients. Some of them do dry eye management afterwards. Some of them will include drops postoperatively for these patients. Some of them have a concierge type service. So I think depending upon what your office does is what your fee should be. We'll put it into the Co-Fi program and it'll collect and go for you, but you need to be the one that can justify that fee postoperatively. And as long as it's documented and you're in your chart and that's your set style of what you're doing and you can justify the fee for the service you're providing, and you're fine. That's the key to it, is doing the service for the fee for the right reason, because that particular patient needs it.
And thank you for that explanation. And I think that, we get that question quite often. So in terms of the fees being commensurate with the services provided, we typically refer to that as fair market value. Fair market value issues were listed as one of the issues in one of the recent co-management settlements, in terms of what the whistleblower had said was inappropriate, and it had specifically to do with premium cataract surgery. So I know you just said it, but I think it's so important. I want to ask you again to reiterate just the importance of fair market value and setting fees that are appropriate with the services that you provide, because in that particular settlement, the whistleblower said that they are quote unquote paying ODs for referrals. And then when they went to the optometrist to ask them what services they're providing, many of them couldn't answer that question. They said, well, we're seeing those patients for postoperative care, but postoperative care is covered under the global period. So that's not an acceptable answer for charging an additional fee for premium cataract surgery. So can you just finish up that point one more time on fair market value for services that they provide?
Yes. And I think also some of the lawsuits were like contracted, right? You have a contract with this particular place to co-manage these patients for this price, where that's not necessarily the case because every patient is a little bit different. And sometimes you keep them longer and there was never a change. If the patients didn't go back, they would still pay for them. If the patients went back later into the game, they were still paying. So that I think that is where things got a little gray. And you're right, the global period, because dry eye is a known complication, glistenings that they see on the lenses on the edge, things that are known complications from cataract surgery are covered in the first 90 days. If you do additional testing for anything refractive, not covered. Anything to monitor astigmatism, like topography or any OCTs that you're doing, they're not covered. Any type of additional dry eye testing, not necessarily covered, or treatments. So those are the areas where you have to be able to explain what it is that you're doing that isn't already covered by insurance.
Right. Well, thank you for that explanation. I think it's definitely an important thing to consider when setting up those fees. And so when it comes to the global period, is it ever okay for an optometrist to bill insurance during the global period? Is that acceptable?
Not if it's anything that's a known complication of cataract surgery, but patients have other things that happen to them during life. So yes, if they have an unrelated diagnosis that's not related to their cataract surgery, then they can bill that as an office visit through their insurance for whatever the reason is. I mean, if they get pink eye in the middle of that, or they get picked in the eye with a stick while they're working in the yard, or something to that effect, those don't have anything to do during that 90-day window, then yes, they can bill the insurance for that.
And another question we hear too is from some optometrists is when they should start seeing the patient for routine eye care after a co-management episode.
Generally speaking, if they feel the patient has a disease process that needs to be monitored, such as glaucoma, on a more recent or frequent interval than annually, then that's up to them to decide. Majority of people do start annual CEs 1 year from the episode of the surgical event, somewhere in that window, to monitor what's happening. But conversely on that, I would also say that one thing I always try to tell optometrists everywhere is if you have a patient that you've diagnosed with cataracts and they may not quite be ready for cataract surgery, even if they are ready, but mentally they're not ready, because that first time you tell them that you found a cataract, they kind of go into shock. They're either like, hey, I'm not that old yet, or wait, hang on, that's not me, that's my mom or dad. So I think first time you tell them, oh, we have some little cataracts here, and they elect glasses, fine, but don't wait for an annual eye exam to see them back. Make sure you bring them back at a 6-month office visit for that cataract check, because you don't know how quickly they're going to progress or how frustrated they're going to be with those glasses because they're not as clear. And more often than not, I have seen patients not wait that full year and either go to another doctor for another opinion or show up for cataract surgery without the referral. So I think to really keep the continuity of care going and to keep that patient informed, and once they're through the initial shock that they have cataracts, start giving them the options and let them think about it. Generally speaking, LASIK patients, from the time you mention it, take 18 months until they decide they want to have it. I think a cataract patient, once you tell them, unless they come in absolutely ready for cataract surgery because they're sick and tired of their rock hard cataract, then it takes them a little while to process that. And honestly, early referrals of cataract surgery versus waiting until it's a white cataract is so much better on everyone involved. I know every surgeon would tell you they're much happier with that, but the patients get a quicker visual recovery and they're much happier with their experience. They have a lot less edema. So the early referrals of cataracts, as soon as that patient starts to have visual complaints and night glare, is much better for everyone involved.
Makes sense. And thank you for talking about some of the specifics about what to do during a co-management episode. I want to touch on a few of the other things that were mentioned in some of the recent settlements. Some of the things that, so when you gave us your history, you talked about when you started, some of the stuff that at that time was probably very acceptable. So, in-person CE events with alcohol, or taking them to ball games, or, you name it. Yeah, ski trips, or can we just, I guess, can you just talk a little bit about that? I mean, obviously we know those are things that have been changing over the years, but as it relates to this, and, how should an optometrist, if they're approached with those things, what should they do? What should they say?
I think you just have to kind of approach it with caution. But yeah, I was just saying the other night, wow, my very first CE that I took co-managing doctors to many moons ago when I was with TLC actually was in the Bahamas. It was great. I mean, I thought it was awesome. So yeah, things have changed a lot since then. But I think, if you're ever approached with something where you're like, it's too good to be true, it's too good to be true, right? It doesn't mean that you can't go hang out and be friendly with one of the ODs in the office that you work with, or an ophthalmologist. You're entitled to have friends and do things. I think when it becomes a pattern and it's you get this for doing this, that's when you have the problem. But it's not like, hey, it's your birthday, let's go to happy hour. Those kind of things are not frowned upon and be an issue from that aspect, because it's not specific to you're getting this because you refer to me. But I think if there ever is a contract in place, anything that says if you refer me X amount of people, you get to come to the Christmas party or whatever. If you refer me X amount of people, your price drops by $200 each month. Those types of things, they're out of the lane, and it looks like it's being done for the wrong reason, and it probably is.
Asking for trouble.
Mm-hmm.
So if there is they name an ophthalmology practice, and when they do an investigation, they start looking into it and deep diving into the specifics. So in that case, who is liable if there is any kind of a lawsuit or a claim for fraudulent practices?
Really, all physicians that are involved. So the physicians providing the service and the co-managing physician as well are liable on both sides. I mean, they usually start with where the surgery and the checks were written, I think, but I think both sides end up being liable.
And so, we've talked a lot about the things that you started with. So we did the sandwich technique today. You started with all the great things about co-management. We talked about some of the things that, may not be so smart. I think, and the reason I say sandwich, because I think if you're hearing our conversation, some people might be scared away thinking, is co-management bad? Is co-management scary? For those that are hearing us have this conversation and are now starting to break out and have anxiety, how would you answer that question?
They could be having a drink that we didn't purchase. So, but I think co-management exists again for the patient's comfort and ease and the relationship that they've built. And when you're practicing in private practice, there's everything that comes through the door. There's all ages, there's all types of patients, and the variety is what really kind of keeps the fun and excitement of the business. And not participating in any type of co-management or post-operative care of patients coming through really kind of puts you at a disadvantage from knowing what to tell the patients and what to expect. So I think being a part of sharing the care, and even if it's not for every patient, and sometimes there's certain types of patients you're just not comfortable dealing with, and that's totally fine. That's why it exists to be not every hard, fast rule. So once you involve yourself and you're educated on what to expect clinically, what to expect just in the complaints from the patients, you start to feel more comfortable. And there's nothing better than seeing that postoperative, either LASIK or cataract patient, where they can see. I mean, what other profession is there where you can give the gift of sight and take it and make it better? I mean, putting those first pair of glasses on them and they can see things they haven't seen, getting that cataract removed, and they all come in and go, oh my God, the walls are so white, everything's so bright and colorful. And the LASIK patients, it's like, I could see the alarm clock this morning. I haven't seen that in years. I mean, those kinds of things kind of help you get up in the morning and keep doing what you're doing. So, I think cataract surgery will keep evolving. I think ultimately we'll be doing bilateral cases instead of waiting a week apart. And I think that won't be too terribly far in the future because we're looking at efficiencies in the surgery. Insurance certainly doesn't want to pay more. So they're looking at ways to make it more efficient and cost saving on their standpoint too. So I think that will be changing, sometime in the near term future. I think you want to be a part of that and be there for that excitement of the patient early on because they will build referrals for you. It will be a practice building pearl for you when that patient's super excited in your chair and they're like, that's my surgeon and that was my doctor. I mean, that's what you want them to come in and be, because there really is with the baby boomers, there's almost a shortage of ophthalmologists. It's not, they can't really see every patient and do everything. So co-management needs to exist to help take care of the patients in the backlog so it doesn't get too long for the patient.
I think you said it beautifully. In our practice, we know that we can't serve that population without the help of the co-managing physicians because there's just the numbers don't work out. There's just so many patients that need care. Those patients have relationships with their physicians. They feel comfortable with them. So yes, I'm glad that we can end on this note because it's definitely, something that we work hard on every day to make sure that, we can give great care to patients and we help our co-managing physicians help them refer patients and do it the right way and give them resources and just help as in general. And so we can all win and the patient wins. At the end of the day, like you said, the patient wins. And so as we close up our conversation, is there any summary points that are just take-home points you just want to make sure that you hit, or just any few take-home bullet points?
I think keeping in mind, have fun with it. Talk to the patients. Communication is the key with the patient as well as the referring facility and surgeon that you're sending to. So the more information that you can give about the patient's lifestyle and what they like, the better and the easier it is to make decisions that are the best for that patient. And that's another reason why the co-management exists. The co-managing doctor knows the patient and knows their history. So sharing the care is sharing the information as well as just the clinical notes. So I think all of that's important. Co-management is fun. It's not going away. But you want to do it the right way so you're compliant and protected because everybody wants to sleep well at night. So I think doing your research, asking questions is always good. There's information online. You can go to HHS website. It's the Office of Inspector General is the one that brings all these charges and does all the investigations. So if the OIG knocks on your door and asks for charts and records and information, it's not bad. You can get through that. It's just you want to make sure that you have your documentation in place where you need to be and enjoy the patients because it is life-changing for them. The post-op patients are my favorite to see.
Last question, I guess, is anything else that from a practice standpoint that you think Mann Eye Institute, if you were to say for assistance that we can provide help with the practice from a practice standpoint?
We're always here to help. I mean, anyone on our team is happy to take questions, and even if there's no dumb question, right? So whatever the question is, we probably run into it. So happy to help. Or if there's any secondary issues that anyone has concerns on, just email me, you can email you, you can email the girls, anybody, information. Happy to help. I'm passionate about optometry, independent optometry, private practice. So I'm happy to help in any form and fashion to keep it going.
Awesome. Thank you so much. So let's go to the Q&A portion of the CE tonight. Tina and Nicole, are there any questions we can give to our expert speaker tonight?
Absolutely. And first, we wanted to say thank you both. Great information. Thank you. First question, is it within compliance guidelines to work with more than one ophthalmology practice in co-managing care?
Yes, absolutely. And you should. I mean, there's very few people that put all their eggs in one basket, right? I mean, because there may be somebody who is better at detached retinas, or there may be somebody that has better with glaucoma patients, especially really advanced glaucoma. I mean, you really should have relationships with people that are appropriate for the care of that particular patient.
Thank you. My second question, are ophthalmology practices allowed to have optometrists sign a contract to co-manage care with them?
No. Well, I guess they can do whatever they want, but is it compliant? And is that...
No.
No.
Okay. Next question. If I choose to not use CoFi, what is the best way to handle the payment process with patients?
I think if you're not going to use CoFi, that's fine. You just have to collect your fee directly from the patient. That's the easiest way to do that. And it still would be disclosed to the patient. They still know what it's for. I mean, if they're paying a fee, just like anything, if you're going to pay a fee, you want to know what you're getting for that. And so it's just putting it out there in writing that this is the fee that you're paying and this is what you're getting for it.
Okay. And the second part to this question is, how involved is your staff with handling payments for patients either through CoFi or not CoFi?
Well, we run the credit card through, it's basically a terminal, and the CoFi goes out. So we have whatever fee that you're going to collect for your services plugged in. So we plug the information in that you give us, and then we run the card, and it's CoFi compliantly takes that payment, and the patient will actually get on their credit card statement multiple lines. It's not just Mann Eye or Grand Parkway Surgery Center or whatever. It actually has all of them separated out, including the co-managing doctor's practice will be on there with the amount.
Okay, thank you.
We have another question. What is the code used for the fee for premium lenses?
So there's no code because it's not covered by any insurances. So it's a fee, it's a cash fee.
Next question. A recent email from Mann Eye Institute stated, for LASIK, we will continue to see the 1 week post-op in your office the 1 day. Did the email mean to say Mann Eye will see the 1 day and co-managing starts at 1 week?
Yes. For LASIK patients, yes. So most of them we just see 1 day and then they go back. Cataract patients, until they're bilateral, will be a little bit different, and here's the reason. So the first eye of cataract patient is done. Generally, the second eye is done a week later, and it's not really for medical reasons. It's really for insurances. If you do both eyes in the same day, they only pay 50% of the second eye. So you have to have them separated, which is really dumb, and we're trying to help them change that mindset. But if you have them separated by at least a day, most of them do a week because that's the cycle that the surgeons are on, then we haven't released the care of that patient technically. And then you get into something called overlapping care, and the modifiers get confused and it becomes an issue. So you can't have overlapping care where we're still caring for the patient, but we haven't done that second eye, and we have to see them to get, crazy as it is, but we have to get a complaint from the patient before we can go to the second eye. So the patient has to come in and say, yeah, first eye's great, I'm seeing great, but I'm still having glare and halos at night, or I'm still having trouble reading in lighting conditions and it's affecting their lifestyle complaint. They don't always want to give it. We elicit that to make sure that we have that documented before we can proceed with the second eye. See them on the second eye, and then they're generally gone depending on how the case went.
Okay, we have one more question. Is an MD employed OD in compliance if they recommend that the patient has surgery within the practice?
MD employed, yes, because it's not an ownership standpoint. They're in as long as they're an employee, they're okay.
It looks like that was the last question that we had come through.
Thank you. Thank you, Tina and Nicole. Thank you, Dr. Anders, so much for talking about co-management compliance insights. Appreciate your knowledge and expertise. Thanks, everyone, and have a wonderful evening.
Thank you.
Thank you.
Bye.
I also want to take a moment to thank our listeners. We appreciate each and every one of you. We cannot do what we do without you. If you like our podcast, kindly share it with one of your friends on social media. Also, please don't forget to write a review on iTunes or Google Play. Your reviews will help other doctors and practice owners find us. Till we meet again, wishing all of you an amazing week ahead.